Good afternoon, everybody. Welcome back to the new year. Hope everybody had a good holiday. Relax, no illness, no major hazards, and enjoying the cold weather. I'm not, but some of you may be. Today we have a very important topic, cardiomyopathy, something that we deal with almost every day, and Dr. SHAH and I are going to try to give you a very good sense for how imaging helps in this disease, which really is one of these diseases that imaging plays a vital role. Most these patients come with some sort of clinical symptoms, and most commonly dyspnea is one of the symptoms. So therefore, most of the time, the echo lab is the first place where you will see patients coming in with cardiomyopathies and trying to make a diagnosis and then decide what further testing to do. So for that reason, I'll start first, and then we'll have DIPAN talk about cardiac MRI, which is playing more and more a vital role in helping us further tone down etiologies and mode of treatments and prognosis. So what the heck is a cardiomyopathy? It's just a fancy way of saying that there's a disease of the heart muscle. You know, nothing more than that. And there is a structural and a functional component of this disease. So from a structural point of view, not infrequently, we see scars, particularly in the ischemic varieties. We see interstitial fibrosis, which is now becoming more and more possible to identify with cardiac MRI. We see non-infarct patterns of scarring that MRI helps us a lot, inflammation and infiltration. From a functional point of view, there may be ischemia. There may be ischemia due to coronary artery disease, but there may also be ischemia due to malfunctioning of the microvasculature. Frequently, you have cardiomyopathies caused by cardiotoxic agents, and there's a whole gamma of interest in the whole field of oncology. We had grand rounds last month on that topic. And don't forget, cardiomyopathies may also be a response of a chronic pressure or chronic volume overload. In fact, in the literature, you will find the term valvular cardiomyopathies and so on. And then, of course, a whole gamma of genetic mutations that can produce functional and frequently structural abnormalities. Likewise, with the functional varieties, quite often we end up observing also structural abnormality. Now, from a specific disease entities, this doesn't cover them all, but the frequent structural diseases, of course, MI being top of the list, myocarditis, vasculitis, sarcoid, hemochromatosis, amyloidosis. In the functional setting, just plain ischemia, for example, hibernation. It's a condition where you may have chronic dysfunction, a cardiomyopathic looking ventricle that improves after revascularization. And then, of course, the chemotherapy involved, some of the autoimmunes, sepsis, for example. It's an acute cause of depressed LV function. And then, again, pressure overload and chronic volume overloads. And then a whole gamma of genetics. We're going to try to cover only some of the most commonly seen here. The ones in red means that I'm not going to discuss them today. We have already discussed them in other entities. It's just to make awareness that any of these things can cause a cardiomyopathy because they can cause a problem with the function of the heart muscle and the structure. Now, echo helps us to establish a diagnosis. Something is wrong. Hey, this is not a normal ventricle. And then gives us some sort of classification in a general way. Either it's a big heart that doesn't contract well, which would be the dilated kind, or the restrictive kind, or hypertrophics. And then you have some of the other ones that don't fit any specific classification. Sometimes echo can give us some guidelines as to the possibility of etiologies. And very importantly, using volumes, using cardiac dilatation, RV function, hemodynamics, echo provides a lot of help in establishing the severity stage of a disease from a hemodynamic point of view, and of course, gives us a lot of clues towards prognosis in many of these illnesses. So this general classification is one that it's just simply because it's using a phenotypic type of approach. You know, it's a big heart, it's a hypertrophic heart. It's a heart that doesn't look too big, but it has some restrictive hemodynamic components. And then again, a mixed bag of others that don't fit any of these classic descriptions. So when we get to the dilated cardiomyopathies, the most important take-home message, they all look alike. So you see a big heart that doesn't contract well, and then it could be a lot of things, right? It could be ischemic, as we often see, idiopathic, meaning we have no idea, alcoholic, familial, LV non-compaction falls apart because it does have some specific echo appearances that we'll show in a minute. Postpartum, myocarditis, infectious, many of these things, they simply look alike. So the echo tells us there's something wrong with the heart, but then you need a lot more. You need histories, you need some labs, and then not uncommonly, we also rely on cardiac MRI to help us guide us. So look at this, big heart that doesn't look good. It's a young lady who has a postpartum cardiomyopathy. And the only reason you know it's postpartum is because she is postpartum. And you know that there's an entity that has been well described called postpartum cardiomyopathy. It could have been anything else, but the timing is what makes it very likely to be a peripartum or postpartum cardiomyopathy. Important thing about this disease is that it does have about a 50% chance of recovery with therapy in about 6 to 12 months. So it's an illness that, as sick as they can be, there's a fair amount of hope in the horizon for them, particularly now with medications. Another big, bad-looking heart. What is it? It has biatrial enlargement, it's a big back heart, body F, a little bit of MR, functional MR, 45-year-old with acute heart failure. That wouldn't tell us anything about etiology. It could be many of the things that we showed in the previous slide, until you find out that he has positive HIV. And in fact, he has HIV or AIDS cardiomyopathy. So it's putting, frequently the history together with just a bad-looking heart. And this particular patient had been diagnosed for 5 years. He was receiving intensive anti-HIV medication. Very interesting entity. We're seeing a little bit less of it now because actually prophylactic HIV therapy reduces the incidence of this. So I think we used to see a lot more of it years past. However, it's a bad news. When people present with this, they usually have a short survival, increased mortality. Possible mechanisms are still in the literature being debated. Is it an infection? Is it really virus in the myocardium? There's been some issues, some concerns about nutritional deficiencies in some of these patients and even autoimmune problems. And in therapies, there has been, obviously the most important therapy is HIV therapy. But there's been also some studies suggesting that immunoglobulins may help. I think it's not a bad illness. It's not a good news for a patient with AIDS to have this. And I don't think that we've made any major progress in saving them once they present as sick as this particular patient did. The good news is that we're seeing less of it because the prophylactic therapy does work. Now, this is a type of dilated cardiomyopathy that does have a very specific appearance that allows us to make a diagnosis. First of all, note that the heart is not that big. Often these patients do not have huge hearts. They may be slightly dilated, but they don't have these very big hearts that we see in some of the other types of cardiomyopathies. And this is, of course, LV non-compaction, which the feature being all these very, very long trabeculations. So-called spongy transformation of the myocardium, which is the fetal appearance of the myocardium. So basically, it's a genetic disorder where the myocardium remains in that fetal form. Coarse trabeculations, deep recesses that cover a lot of the endocardium. Close to a half of the LV endocardium non-compacted, and these trabeculations do not have communication with the coronaries. And this was from an article in Circa in 1990 showing, basically they created this criteria where if you look at the total length of a trabecula, okay, divided by the endocardial thickness, you have to have, that ratio have to be more than 2. In this case, it's way more than 2. And again, it's one of those things that most of the time when you see it, it's quite apparent. There's some milder cases where people have sometimes argued, gee, is this just a cardiomyopathy that has a little bit of increased trabeculation, or is this non-compaction? So when it's like this, no problem. Some cases can be a little bit more subtle, and I think, again, this is an area where we found either contrast can help, and if not, cardiac MRI definitely can help also. But this type of, when it's like this, I don't think you need much more imaging to make a diagnosis. Hypertrophic cardiomyopathy is an entity which, of course, deserves a conference by itself. We know about the typical hypertrophic obstructive cardiomyopathy, most frequently with asymmetric hypertrophy, i.e. septal thickness much greater than posterior wall thickness, anterior motion of the mitral valve, and LVOT dynamic obstruction, where therefore you see the jet has this dagger shape as the obstruction worsens throughout systole. Now, many patients may have the hypertrophic features without the SAM or the obstruction, and some of them never have it, but many of them, if you provoke them, then they will show it. So this patient shows a nice provocation with Valsalva. Valsalva, exercise, inotropes, amyl nitrate, all those things have been used as ways of provoking the obstruction. I think in our echo lab, most of the time, we first go to Valsalva because it's fairly easy to do. And then I think after that, we also try exercise. I don't remember the last time we had amyl nitrate given in the echo lab. It's not fun to do. Everybody from echo lab, from technicians to nurses, walk out with a headache, and patients, of course. At one time, we used to give dobutamine, but I think we have also kind of stopped doing that. So I think today, our hypertrophic cardiomyopathy clinic, I think, relies more on simply Valsalva maneuvers and some exercise. Important message is that the severity of obstruction has no relation to LVH. You can have just a little bit of sigmoid septal LVH. You may have a lot of massive LVH. There's no relation whatsoever. In fact, the SAM and the dynamic obstruction relate more to changes in the geometry of the mitral valve. And that, again, has been a subject of wonderful research. The group in Boston, particularly Dr. Levine, did a lot of very nice description of the changes with elongation of the posterior leaflet, certain subtle changes, the papillae muscles being displaced more anteriorly, and then, of course, the geometric shape of the LV and the hyperdynamic function of the LV. And that's why the smaller the cavity, the more hyperdynamic it gets, the more likelihood for SAM. But it's, again, you have to have certain changes in the mitral valve structure for SAM to occur. And that's why sometimes we also see SAM with acute MIs. When patients that come in with very dynamic contraction at the base, if these patients have those changes in the mitral valve, they can provoke the SAM. So there's no relation between SAM and severity of LVH. That's the important message. Also, clinically, when the diagnosis is not this pronounced, when somebody just presents, let's say, with LVH, we have to look for secondary causes of LVH, such as hypertension, AS. Of course, the athlete heart has been a subject of a lot of interest discussion. And then cardiac amyloidosis may look like a hypertrophic cardiomyopathy. It looks like a hypertrophic heart with a small cavity. The tip of there, we'll see more examples later, is that there is a relative break in relation between the amount of quote-unquote hypertrophy and the EKG QRS voltage. And then sigmoid septum in the elderly is an entity that, is still out there. Is this some sort of an old person that has some sort of genes, or is this something else? And we see that a lot, little old ladies particularly that have that sigmoid-shaped septum. Some of them, under right conditions, can develop SAM. We've seen some of these little ladies come in with sepsis or some sort of hyperdynamic state, and they can get SAM. So to be honest, I don't know that we know for sure what the heck that is from the point of view of is it a milder form of the genetic disorder, or what is it? And then there's some real rare diseases that at times we may have to think about. Fabry's disease, glycogen storage, mitochondrial myopathies, Friedreich ataxia. These are all diseases that could look like hypertrophic cardiomyopathy. Of course, a tumor can infiltrate the myocardium and at first glance make you think of a hypertrophic cardiomyopathy, and occasional mural thrombus, although I don't think that's That's a common problem of differentiation. You should also know that although asymmetric septal hypertrophy is 90% of these patients, about 5% come in with concentric LVH, with or without SAM, okay? One question is this concentric LVH just a phenotypic expression of the genetic mutation they have, or is it that they have so much obstruction, LVOT obstruction, that they get also secondary posterior wall hypertrophy? Interesting discussion, because quite often you can see some of this concentric LVH with a lot of SAM and obstruction too. Then we have these rare ones. To be honest, I don't remember the last time I saw this last one here. This we see very rarely. This is the one we see most commonly. The apical hypertrophy variation, which is interesting. In the Japanese spectrum, they tend to be a little bit more severe in terms of the clinical course. In the US, we see patients with this that overall are doing very well. So this shows you up here, just for comparison, the typical hypertrophic cardiomyopathy, and here you have the apical version where you may have some hypertrophy at the base, but it's just a lot of apical hypertrophy with obstruction at the apex, so that if you do an LV angio, for example, you have this very classic apical trapping that looks like an ACE card. So very typical appearance, and a very typical EKG. These are the people who come in with these wild-looking diffuse T-wave changes. If they come in with chest pain, if they're homeless, they can walk around hospitals in Houston, come in with chest pain, get that EKG, and at least spend one night in the hospital. So, it's one of those EKGs that if you go to an EED emergency room with chest pain, they'll look at this and say, oh my God. But this is chronic. They walk around with it. They can be actually pretty asymptomatic with these findings. And then in terms of making a diagnosis, this is important take-home message I'd like to give you is that this condition can be missed often by echo, because that apical hypertrophy produces a certain amount of attenuation, and if you're not careful, you'll go through an echo test and you will not make a diagnosis. So you have to be careful about thinking about it, and for the sonographers in the lab, in the conference, the short axis view is pivotal. If you get on the habit of trying to always get down towards the apex and do an apical short axis, you will pick up a lot of these diseases, because you see at the apex, basically there's no cavity. And you have this massive hypertrophy. So a well-done short axis at the apex can be extremely helpful. Color can help also sometimes, because you might miss it by 2D, but then the color shows you that there's something weird going on here with trapping of the blood. And then contrast, of course, gives you beautiful demonstration. If you do contrast, you should not miss ever any hypertrophic cardiomyopathy. But you have to suspect it so that you are willing to spend $100 popping a contrast ampule and also putting an IV. So it's a thinking of it. Otherwise, patient may go through a lab and that be totally missed. And we have missed them in the past. So the sonographers, you are the first line of thinking through it and being suspicious of it. So let's talk a little bit about this group of infiltrated restrictives, a bunch of them in here. Obviously, amyloid being the one that we see the most commonly. This is an amyloid patient, because I'm telling you, right? I mean, if you look at that heart, what do you see? You see hypertrophy, okay? Oh, yeah, there's a little bit of prominence, speckle appearance. That's the worst criteria you could think of. I could show you some wonderful chronic renal failure patients that have that wonderful speckle appearance. So that would be the least thing that you would look for. Basically, you have concentric LVH, what looks like LVH, with a EF that can vary all the way from normal to pretty bad, as I'll show you in a minute. You have somebody with some symptoms. Bilateral enlargement is a very common finding. EF varies all over the place. Diastolic dysfunction is universal. It's universal. And this last thing is, it's extra credit if you see it. But the very important thing here is that you have a discrepancy between that level of apparent LVH and then the EKG. Because EKG may have low QRS voltage, or may just simply have low normal QRS voltage. But you're expecting an EKG with big time voltage, and then you find something that doesn't match. That should be one of the very first lights that blink in your brain, whoops, to suspect amyloid. Now, it comes in all kinds of gradations. This one, you can see severe impairment of the E prime with already a pseudonormal pattern. So this patient is in a much more advanced stage. Look at this one. This was a very, very sad case that I saw when I was rounding, in the days I was rounding in a weekend, and this lady was in her 40s, and she had been going from one cardiologist to another for almost a year, got cast, normal coronaries, and she just kept hopping from one until finally she came in sick, like very, very sick in the ICU. And by then, basically the game was over, as you can see here. Very, very severe dysfunction at this point in time. Everything was bad. You can see the TVIs were low. Look at the stroke volume was very poor. So at this point in time, there's not much you can do for it. Now, I want to also talk about this because more recently, there has been these literatures on spectral tracking helping us with cardiac amyloidosis because the apical segments do appear to contract better than the basal segments. And therefore, when you do the final bullseye, you see that areas in the apex are higher values for longitudinal strain than the mid and basilar segments. And certainly, yes, you see that that should make you put it together with everything else and say, this is all compatible, we should be thinking of amyloidosis. But, and this particular picture here is from a biopsy-proven amyloid patient. However, look at this. This one is gorgeous, beautiful. Patient with aortic stenosis. So I can show you some ASs, I can show you some end-stage renals. We have them in the file. So this is not, this is not the final wonderful diagnostic proof of. It's just one more thing. If you see it together with everything else, hey, think of it. DIPAN is going to tell us more then about how MRI can help us to get more in depth. There is several prognostic markers. Certainly enzymes. These people can spill a lot of troponin, high BNPs, the restrictive physiology. As the EF gets worse, bad news. And if the RV goes down, very bad news too. So there's a lot of things that can be detected that allows some prognostication. Now, here we have a patient that, as you all can see, has an EF that is not perfect. We might say 40s, at most maybe right around 50, but it's not a normal EF. Overall contraction is mildly hypokinetic, all right? And notice that the LV is not particularly dilated. And these are relatively common features of what this patient has. So what's the diagnosis of this patient? So the biggest clue is not in the echo, it's right here, okay? And the biggest clue is that this patient has a very long PR interval, okay? So that this is not an E wave, this is a summation EA wave. So diastology goes down the drain because this is not an E prime, this is a summation EA prime. So patient probably has diastolic dysfunction just because he has an abnormal myocardium, but you cannot say much about diastole here. And this prolonged PR interval with a PA pressure that appears to be high is about 3.5, it's about 48 millimeters of mercury plus the RA should make us think of, and if I tell you the patient has had some chronic pulmonary problems, then you might make a diagnosis, right? Sarcoid. So sarcoid is actually a tricky one. And sarcoid, I think, is one of the diseases where the MRI really is going to play a big role because that one is more tricky. You can see here, whenever you see a lot of things listed, you know that you don't have a stamp on making a diagnosis. So yeah, of course, the diagnosis is histologic. I mean, that's the ultimate proof is by histology. And then you can have in the EKG, you can have prolonged PR, right bundles, left bundles, a lot of electrical blocks, but you can also have PVCs, VTAC, you name it. They can have perfusion abnormalities by nuclear. So imagine, patient comes in, you're thinking coronary disease, you do a nuke, oh, it's positive, you end up in cathing, coronaries are normal. And they can have, of course, abnormal hemodynamics based on how severe this stage of the disease. So CMR really, and probably DIPAN will talk more about it, I think it's tremendously helpful. And in essence, you have to suspect, basically, how do you suspect this? Well, either the patient has non-sarcoid. So if somebody has already non-sarcoid and they have any form of EKG or echo abnormalities, cardiac involvement has to be way up. Problem is, if the patient presents primarily from the heart point of view, then it becomes a little bit more tricky. What about this one? Everything is bad. The RV may be even worse than the LV. Biatrial enlargement, very, very sick heart, right? The TR is so severe that we don't even see any color. You see valves that are trying to say hello to each other a mile away, and there's nothing here. And because it's like not having a tricuspid valve anymore. So obviously, the answer will be severe. And the diagnosis comes in by a blood test. So once you have a ferritin that is sky high, then you know what the patient has, right? Hemochromatosis. So another disease that has no distinct echo features is made by either finding echo abnormalities in someone already known to have hemochromatosis or suspecting in a patient presenting de novo. And that's why I think a serum ferritin should be one of our list of labs that we do in anybody coming for the first time with a cardiomyopathy looking ventricle. It's a cheap, very simple test, and if somebody has hemochromatosis, they ain't going to have a borderline ferritin. So very simple test. Now, MRI will give us great information, but the truth of the matter is that a ferritin will give you a lot of information and with a much lower cost. I think to me, in my opinion, where MRI plays the biggest role is when somebody already has hemochromatosis. They look well, and you're trying to pick up early stages. And I think DIPAN probably will talk more about that. But that's where I think the money is in the MRI. Because at that point in time, the echo might not necessarily give you all the information. Okay. What is that? Is this an apical hypertrophic cardiomyopathy? Could be, right? It looks like. However, notice that, and I'm going to see if I can stop it. Notice that the appearance of this here is a little bit different to the myocardium. A little bit different to the myocardium. Okay? Now, if I tell you the patient has a very high eosinophilia, hopefully most of you will know the diagnosis, right? So this is left lateral endomyocardial fibrosis, a condition that is rare. This is courtesy of Susan Wheeler, who lent me this slide. This is a beautiful example. It's also known as hypereosinophilic syndrome. There is a tropical variety infectious from schistosomiasis, which actually it was endemic in Puerto Rico, but I never saw a case. We have a lot of schistosomiasis in Puerto Rico, but I never saw a hypereosinophilic. In those days, I was probably in another planet. But we see more, I think in the US, we see more of the other type, the hypereosinophilic, not the infectious type, the non-tropical. And it's a disease that if you don't catch it, it doesn't have a good course either. You can have a lot of MR because that stuff infiltrates, and you can do LV and RV. Both can be affected. You get restriction of the mitral valve, so the coaptation gets out, and then these people can also come in with a lot of MR. At one time, the only treatment was surgical. And you needed a surgeon with gray hair because you need a surgeon that had been exposed to those illnesses. And you basically you go in and try to scrape that stuff out. Now, I think there's a lot of emphasis on the new modes of therapy, either low dose imatinib, which is a chemo type agent, immune suppression, even steroids, hydroxyurea. This is an illness, of course, that if you make a diagnosis, then you call some experts because it's a rare disease. But the good news is that now there are some medical treatments that are making an impact. The bad news might be that we may be losing the surgeons that have the knowledge of being able to go there and remove that substance out. It's not a common disease. We go years without seeing one. And of course, this is a slide I'm sure DIPAN will show again, is that in a lot of these restricted cardiomyopathies, the prognosis, if you make a diagnosis already when they come in sick, with a lot of the findings that I just showed you, the prognosis is usually very bad. So the take-home message here is, anybody that we see in the clinic that has symptoms, that the echo shows some features, some abnormalities, you're not very sure. Heart is not huge, baggy, it's more normal. You may have a lot of diastolic dysfunction. These are situations that we have to start thinking, putting particularly things like amyloid, which are the ones that we see more commonly, up in our radar screen, because otherwise we can miss them, as it happened to that old lady that I saw in the ICU many years ago. So this is very important. And lastly, I like to just touch a little bit about others, this other category. Takotsubo, you all know it very well. It looks like an acute MI. This is the typical apical variant where you have what looks like an LAD infarct. 10 days later, perfectly normal and normal coronaries. Then you have these other ones where you have this involvement of territories that do not match a blood vessel. So this patient has, you can see the apical long axis here with recovery. In the two-chamber view, we can see abnormalities at basically a mid variant. And that doesn't fit any particular vessel. That's another one of the clues. The typical thing here that makes it always come up in the radar screen is that many of these cases are associated with a significant stressful situation. Argument, somebody being mugged, a patient that I saw in the process of being intubated had a very stressful intubation, and then after that expressed the entire picture of Takotsubo and recovered too. So the interesting thing is that now they actually have an animal model. So there is rats exposed to physical stress, and they express the disease. So more and more, there is good evidence that it's a form of catecholamine toxicity. It's a form of adrenaline toxicity. Very interesting condition. Most of the time, they do recover. This one, I'm going to bring it up to say that, yes, there are some echo features. There are echo features. This is taken from the literature, showing RV enlargement, RVOT enlargement, which is quite common, and aneurysmal segments, particularly in the apex of the RV. And of course, you can have RV dilation and RV dysfunction. So echocardiographically, think about it. If you have an enlarged RV or RVOT, if you have any type of RV dysfunction, whether it's overall global or segmental, strain perhaps may give us some extra help. I think it's still work to be done. Exclude other causes of RV enlargement. The LV could be normal, but it has been involved too. But this is part of a constellation of clinical findings and EKG findings. So this is just the imaging part. But as you know, this patient clinically present with arrhythmias. EKG can have an epsilon wave. So again, it's putting the echo together with a young person that has certain arrhythmias type. They may have even had an episode of quote-unquote sudden death. EKG abnormalities, and then you put it with some echo findings. Today, of course, we have MRI to help us a lot in this diagnosis. So I have been, I'm sort of being the how you call it, the small band to preparing for the big band. So, so Dr. Shah, you don't have to do many slides here saying that MRI is better than echo. I mean, those times are over. Tell us about how MRI takes us to the next level of diagnosing. Let me take this out of here.
So not competitive, but complementary, right? Okay. Let me turn this on here. All right. And let's get this to screen mode. Okay, and so I'm going to skip past the first few slides here because I think we've already touched on the fact that the first thing when you have a patient with heart failure or with cardiomyopathy is really to trying to stratify whether the patient has reduced LV function or normal LV function. So again, this classification of HFrEF versus HFpEF. And then obviously the reason that's important is because we know that most of our therapies to date are really based on treating patients with HFrEF, with reduced ejection fraction. I think there's still a lot more work to be done in trying to identify the best way to treat patients with preserved ejection fraction, but with heart failure. And so, echocardiography, again, is going to be your first line modality. And then in cases when the echo is suboptimal or there's a question, that's when you could proceed on to CMR for assessment of LV function, as well as volumes and contractility. The second thing you want to know, so the first thing I think is you want to know what's the patient's ejection fraction and what's their volumes. The next thing you want to know is this LV dysfunction or this cardiomyopathy due to coronary artery disease, or is this due to something other than coronary artery disease? And the reason, again, is because we know that if it's due to coronary disease, the prognosis is very different than if it's due to non-ischemic disease in general. So as we can see here from this publication, almost 15 years ago, patients in general with ischemic cardiomyopathy have a worse prognosis than patients with a non-ischemic cardiomyopathy. And so cath is going to be one of the ways that you do that to try to identify whether it's ischemic or non-ischemic. But there is a role, I think, for imaging as well, whether it be PET, whether it be nuclear scintigraphy, dobutamine echo, and then also for cardiac MRI. And we're going to have a whole lecture in a couple of weeks on the role of imaging in ischemic heart disease and assessment of myocardial viability. So just kind of stay tuned for that. What we're going to touch on today is for people who have non-ischemic heart disease. So, I think the first thing obviously is, let me skip past this here in the interest of time, which is, let's go here. How do we know that somebody has fibrosis that's due to a non-ischemic etiology? Well, the one thing we know is that there's this wavefront phenomenon that occurs with ischemic heart disease, with ischemic injury, which is that you begin to affect the subendocardium initially, and then it progressively extends itself outward to the mid-myocardium, and then gradually, after about 6 hours or more of coronary occlusion, you begin to have transmural injury. So if you see a pattern of hyperenhancement or pattern of fibrosis that's confined to the middle of the myocardium, that's a clue that this is not due to an ischemic etiology, that in fact this is non-ischemic fibrosis. If you have epicardial hyperenhancement, again, sparing the subendocardium, and then lastly, if you have kind of this global pattern of subendocardial hyperenhancement, that's also a clue that this in fact is a non-coronary pattern of injury. Now, the patterns of fibrosis can actually help us, I think, in trying to identify what the potential underlying etiology is. And as we've seen, knowing what the underlying etiology is can be very important because it has very significant prognostic effects. So here's just a list of some of the different non-ischemic cardiomyopathies that CMR can be helpful with. And in the interest of time, I'm not going to go through each of these, but I'm going to try to highlight some of the ones that I think are key. So first off, I think is RV dysplasia, or ARVC, arrhythmogenic RV cardiomyopathy. Now, one of the things to keep in mind is that there's a number of criteria that you need to have to make this diagnosis. And imaging only provides one of those criteria. So you need clinical history, you need family history, you need EKG findings and other things. But what are the imaging criteria? And specifically, what are the MRI imaging criteria? And those are shown here. And it's basically defined as either major criteria or minor criteria. And in fact, this really doesn't require a lot of memorization. It's fairly straightforward. And the first thing is you got to have some type of abnormal wall motion. So whether you're talking about a major or minor criteria, it starts with regional RV akinesis, dyskinesis, or desynchronous contraction. So if you have completely normal contractility, then it doesn't matter what these other parameters are, which really basically involve size of the ventricle and ejection fraction of the right ventricle. But if you have this initial abnormality where there's some wall motion abnormality, then the next thing you look at is what's the size of the right ventricle. So if the RV end diastolic volume indexed to the BSA is greater than 110 for a male or greater than 100 for a female, that fulfills a major criteria. Or if the RV ejection fraction is less than 40%, that fulfills a major criteria for ARVC. And then secondly, minor criteria would be if the RV end diastolic volume for a male is between 100 to 110, and for a female is between 90 to 100. So again, just 10 mLs per meter squared less. Or if the RV ejection fraction is between 40 to 45. And then again, to make the diagnosis of ARVC, you need two major criteria, one major criteria plus two minor criteria, or 5 minor criteria. So again, this doesn't make the diagnosis, but this provides you with criteria that supports the diagnosis of ARVC. So let's move on to hypertrophic cardiomyopathy. And we talked about this a little bit already in the first half of the lecture. The first thing you want to really look for if you're looking for apical hypertrophic cardiomyopathy is what's the location of the hypertrophy. And CMR is excellent at being able to identify thickness of the myocardium without the concerns of foreshortening. And we can see in this case that there's pretty significant hypertrophy of the apical segments only. And when we do our delayed enhancement imaging, we in fact find that in this patient that apical trapping has led now to an infarct in the apex. So you can oftentimes see in these patients an apical cap infarction. Now what about the more garden variety form of hypertrophic cardiomyopathy, which is going to affect the basal segment more than anything else? And what you can see, not only is there hypertrophy, but in fact there's evidence of fibrosis manifested by hyperenhancement here. But what's usual about this is that it's in a location in the middle of the myocardium at the RV junction sites, at the anteroseptum and the infraseptum. And again, this is one of the classic findings that you see with CMR in the setting of hypertrophic cardiomyopathy. And again, this is not a pattern of fibrosis that you would expect from coronary artery disease. What we know from histology studies is that this obviously is the area of the greatest myocardial disarray, and it's because you have LV fibers coming in at one angle and RV fibers coming in at a different angle. And so this is an area that's more predisposed to develop fibrosis. And there's autopsy data correlating, in fact, the fibrosis that we see by CMR and evidence of fibrosis that you see at the time of histopathology. Now, what's the importance of this fibrosis? Well, so this was a nice publication from a few years ago of about 1,500 patients, multi-center observational study, where they looked at the quantitative extent of fibrosis in patients with a known diagnosis of hypertrophic cardiomyopathy. And what they found was, in fact, as the extent of fibrosis increases, the freedom from sudden cardiac death goes down. So in other words, the likelihood of sudden cardiac death increases with an increasing scar burden. Furthermore, increasing scar burden, as is shown here on the y-axis, the x-axis, was also correlated not just with sudden cardiac death, but also with increased mortality from end-stage Holcomb as well. So in fact, increasing fibrosis burden leads to both arrhythmic complications with hypertrophic cardiomyopathy, as well as the pump failure and the end-stage heart failure complications that can occur with hypertrophic cardiomyopathy. So to summarize, CMR, I think the role that it has is one in identifying ventricular morphology as well as function in patients with hypertrophic cardiomyopathy, has the ability to identify fibrosis in patients with hypertrophic cardiomyopathy non-invasively, and it has the ability to predict all-cause mortality as well as sudden cardiac death risk in these patients. Now, let's move on to Takotsubo's cardiomyopathy. And again, we have these Mayo Clinic criteria for diagnosing Takotsubo's cardiomyopathy. And really, I think that the mainstay of this is that there's EKG abnormalities, that there's angiographic evidence of coronary disease, that there's reversible regional wall motion abnormalities that extend beyond a epicardial coronary distribution, and it has to be in the absence of other conditions that could mimic this, such as hypertrophic cardiomyopathy, significant intracranial trauma, acute myocardial infarction, and things like that. Now, this actually is a very nice multi-center study that I want to highlight of 239 patients that presented with Takotsubo's cardiomyopathy. And what they found was, in fact, that most patients, in fact 82% in this cohort, presented with the classic apical ballooning syndrome as you see here, which really you could say looks like an LED distribution type of wall motion abnormality. In fact, about 17%, so close to 1 in 5 patients though, presented with a mid-wall ballooning pattern as is shown here, where the basal segments and the apical segments are spared, but the mid-wall segments are the ones that are affected. And then a very small percentage, 1%, actually presented with what they refer to as a inverted ballooning syndrome, where really the basal segments are affected. So again, we think of it as classically the apical segments, but keep in mind any of these segments can be affected. And then, in fact, in about a third of patients, there was this pattern of biventricular ballooning where the RV is affected as well as the LV as well. Now, one of the things with Takotsubo's is when we do our delayed enhancement MRI, in fact, we don't find evidence of myocardial fibrosis. So again, this is a patient who presents with one of these classic wall motion abnormalities, obviously with that clinical history. And when you do the delayed enhancement MRI, despite having this huge wall motion abnormality, there's no evidence of myocardial fibrosis that's present. And then, importantly, these patients tend to have a fairly good prognosis. And so in this particular study here, when they looked at patients at follow-up, and the mean follow-up was done about 3 months later, most of these patients, the mean ejection fraction completely normalized, and the mean end-diastolic volume also shrunk down to normal. So there's both improvement in contractility as well as reverse remodeling of the ventricle that happens as kind of the natural history of Takotsubo's. Now, let me move on to another condition, myocarditis. And this is a common referral that we'll see in the CMR lab. And again, I like to highlight this publication. This is almost 13 years old now, from 2004. And this was a German group that studied a series of patients that presented with suspected myocarditis. And I think what was really unique about this study was that all these patients underwent a CMR scan, but they also underwent biopsy in the left ventricle at the site where the hyperenhancement was identified by CMR. And in fact, what they find in these patients, a couple of things I want to highlight. One is, again, a pattern of hyperenhancement which doesn't really fit with what you would see in a coronary distribution. In this case, the epicardium of the infralateral wall. And by histopathology, what they found was that in the vast majority of these patients, there was actually active virus present when they biopsied again. Now remember, this is not biopsying in the RV. This actually is biopsying in the LV itself at the location where the hyperenhancement was identified. And about a quarter of the time, it was herpes type 6 virus, and about 2/3 of the time, it was parvovirus B19. Now, in addition to that, this was a follow-up publication from the same group where they actually noticed that different viruses tend to affect different parts of the myocardium. So most of the patients with the parvovirus, which again affected about 2/3 of the cases, presented with more of a lateral wall pattern of hyperenhancement, whereas those patients with the herpes type 6 virus tended to present with more of the septal pattern of hyperenhancement. So again, myocarditis can give you injury in multiple different foci. It can give you injury in any wall. But in general, parvovirus tends to have more of a predilection for the lateral wall, whereas herpes type 6 virus tended to have more of a predilection for the septal wall. And then lastly, the presence of hyperenhancement is associated with a bad outcome in these patients. So again, this was a large series of patients that presented with clinically suspected myocarditis. And if they had no evidence of delayed enhancement on the CMR, then the prognosis in these individuals was quite good. Whereas if they had evidence of any hyperenhancement evident, then the prognosis was much worse. And really that's looking at multiple endpoints, whether we talk about all-cause death, cardiac death, or sudden cardiac death. Again, the presence of hyperenhancement in a patient with suspected myocarditis is associated with a bad outcome. Here's another condition. And if I show you the CT MRI, I think most of us would say, yeah, it looks like there's some findings here that raise suspicion of something, but I don't think anyone could raise their hand and say they know what the diagnosis is. And what do we see here? So we see, one, a small pericardial effusion. We've got LV hypertrophy. In fact, the LV measured about 1.6 centimeters. We've got RV hypertrophy as well if you look at the short axis or the long axis views. And the RV measured about 0.8 centimeters. We have biatrial enlargement, as you can see here on the 4-chamber view. We have a mild LV dysfunction. The EF here measured 47% for the LV, and the quantitative RV EF was 38%. LV mass was increased. But again, I think if we looked at this, is this a dialysis patient? Is this an amyloid patient? Is this a bad hypertensive patient? I think none of us could make a definitive diagnosis just based on those images alone. If I show you the delayed enhancement findings, however, I think it becomes very apparent. What do you see here? So we see really this very classic pattern of diffuse hyperenhancement affecting both the LV as well as the right ventricle, also affecting the atrial walls, affecting the papillary muscles, as you can see over here. And this really is a pathognomonic finding on CMR for amyloid heart disease. And again, the way that this diagnosis is made is some people who have known systemic amyloid who come in to evaluate if there's cardiac involvement. And oftentimes it's patients that are just presenting with heart failure. And then CMR really is identifying the first clue that the etiology of this heart failure is in fact amyloid heart disease. Now, this not only is useful from a diagnostic standpoint, but it's also useful from a prognostic standpoint as well. And in this particular study, this was a multi-center study where patients that presented with biopsy-proven extracardiac amyloid, if they had evidence of late gadolinium enhancement by CMR, their prognosis was very, very bad compared to those patients with known extracardiac amyloid who had no evidence of late gadolinium enhancement. And in fact, the CMR was a better prognosticator than clinical history based on New York Heart Association class 1. Even class 1 here, you can see the prognosis is not very good. So again, CMR I think helps identify prognosis in these individuals. And then this now is just a multi-center study that we were involved with, which again showed the same finding, which is that if you have evidence of hyperenhancement and known extracardiac amyloidosis, your prognosis is very poor. Now, let's move on to another case. This is a 44-year-old woman. This was a case we had a couple years ago here, who presents with really no known past medical history, but she's had 2 episodes of syncope within a week. The first episode, she saw her doctor, EKG, everything was normal. She reports, however, that she's had about 6 months of shortness of breath, no chest pain, no palpitations, and really all of her non-invasive testing was normal. Echo was normal, EKG was normal. I'm sorry, not the EKG was normal, but I'll show you the EKG here. Okay. Anyone want to take a look at this? Okay, complete heart block. So right off the bat, what are you thinking now? Okay, so you're thinking very good, and I'll show you what the guidelines recommend with regard to this. Let me skip past some of the other stuff and get to the key findings here. So if you look at the echo, let me see. So I guess we will not do a comparison to echo because it won't play for us, but the CMR plays for us. So what do you see? So you've got obviously hypertrophy of the septum, right? You've also got an area of hypertrophy here in the lateral wall. And what about contractility? How does it look? Looks normal, right? Okay. So based on this, we'd say normal LV function, but there are a couple of areas that are hypertrophied. Now, this is where, if I show you some of the other findings, which is look at the late gadolinium enhancement, what do you see? Yeah, so you've got basically this lateral wall, which shows some hypertrophy, actually in fact shows hyperenhancement as well. And if you look at the septum, also, this area right here that was hypertrophied also shows hyperenhancement. Now the other finding that's interesting is what about the RV? If you go back and look, the RV wall also is thickened as well, right? Parts of it. Localized parts of the RV are thick, and there's hyperenhancement present in this area as well. And in this particular case, we also did a technique called T2 or edema imaging, and you'll notice there's increased signal in these areas where there's hyperenhancement that we saw, right? That tells you that this is acute hyperenhancement due to increased myocardial water content. And so obviously, you put this together, coupled with the next image, which I'm going to show you, which is this right here, which is the just simple morphologic images through the chest. And if you pay attention, I know we're not radiologists here, but pay attention to the parahilar and the paratracheal area. You see a lot of little nodules, right? Fullness. This actually is evidence of lymphadenopathy. And again, so in every CMR scan, we'll always do some morphologic images through the chest as well to see if there's associated other abnormalities in the chest. And so when you put all this together, obviously, as Man said, these findings, hypertrophy in the basal septum, lateral wall, RV free wall, gadolinium enhancement in those same territories, as well as increased water content, is really all suspicious in the presence, obviously, of adenopathy of acute cardiac sarcoid involvement. And so this was an example of a patient who presented really with not a known diagnosis of sarcoid, but rather with a cardiac complaint, who now the CMR is useful in actually pointing you towards, one, that there is a myocardial abnormality, but secondly, actually potentially what the diagnosis is. Now, as was touched on earlier, how do we diagnose cardiac sarcoid involvement clinically? Well, it's based on these Japanese Ministry of Health criteria, and it's really looking for abnormalities in the EKG, abnormalities in wall motion, perfusion abnormalities, or abnormalities in LV function. And in the interest of time, let me skip past this here, but let me just kind of show you in one particular study where they looked at a series of about 100 patients, in this case with known extra cardiac sarcoidosis, but instead performed CMR to see if there's cardiac involvement. You can find that there's hyperenhancement that you see in multiple different patterns. It can be transmural, it can be mid-myocardial, it can be epicardial, sometimes affecting the RV, or you can actually have multiple patchy foci. And so again, the pattern of hyperenhancement or pattern of injury with sarcoid, I think, can be a great masquerader because it can really be anything. Any pattern of injury can occur with sarcoidosis. In this study, what they found was that by CMR criteria, just looking for evidence of hyperenhancement, there was cardiac involvement in about 25% of patients in this series versus Japanese Ministry of Health criteria, which are abnormal only in about 10 or 12% of these patients. And then when you look at prognosis, again, known extracardiac sarcoid, if there's evidence of hyperenhancement by CMR, the prognosis in these individuals is much worse. And again, this was looking at all-cause mortality, symptomatic tachyarrhythmias, or symptomatic bradyarrhythmias. And then let me skip past this here. To kind of summarize, I think what this particular study showed was that cardiac MRI is twice as sensitive at identifying cardiac involvement compared to the consensus Japanese Ministry of Health criteria, and that the presence of this myocardial damage that you see by cardiac MRI in patients with known extracardiac sarcoid is associated with future risk of adverse cardiovascular events. Let's get past this here. And that was just showing essentially multi-center meta-analyses showing the same findings. And so again, I think that to wrap up for sarcoid, here's what you look for. I think if you have somebody who has known extracardiac sarcoid, CMR can be useful to identify cardiac involvement. But on the flip side, if you have somebody who presents with unexplained Mobitz 2 or third degree AV block, but who's under the age of 60, somebody who has VT of unknown origin, or somebody who has heart failure, CMR could actually be useful to identify essentially cardiac involvement and therefore then lead you to potential diagnosis of cardiac sarcoid. So I think in this case that I showed you, this was a very astute electrophysiologist at an outside hospital who basically said, hey, we need to transfer this patient in because you've got a 40-year-old lady who's now needing a permanent pacemaker with heart block. The concern is that there could be some underlying myocardial abnormality. So they actually transferred her here to get the CMR scan done. And then based on this diagnosis, she went on to get a permanent pacemaker and then subsequently had the diagnosis of sarcoid confirmed. So a couple other conditions, non-compaction cardiomyopathy. And again, we look for those deep recesses, these heavy trabeculations within the myocardium, as is shown in this example here. Now, the CMR criteria that we typically utilize is called a Peterson criteria. And these look for a ratio of compacted to non-compacted or non-compacted to compacted myocardium of greater than 2.3 in diastole. So again, it's a slightly different criteria than what it is in echo. But again, this is what the CMR literature suggests. That seems to be one of the criteria that you can use to identify the presence of non-compaction. And then lastly, let me go back to those kind of garden variety non-ischemic cardiomyopathy that's not due to another cause, the idiopathic cardiomyopathy that we see quite frequently. Well, in fact, there may be a role for CMR even in these patients, and it's because patients with idiopathic dilated cardiomyopathy can in fact also have evidence of fibrosis within the myocardium. And it tends to affect the septum, and it tends to be kind of this mid-wall pattern of hyperenhancement. What's important is that these patients tend to have a worse prognosis. So this is a marker of a more advanced, a more significant non-ischemic idiopathic cardiomyopathy. And in this study out of England, they found, in fact, that those patients with idiopathic dilated cardiomyopathy who had evidence of fibrosis had worse all-cause mortality as well as worse cardiovascular mortality or need for heart transplantation. And also, the incidence of sudden cardiac death was worse in this group as well. And then this now is just a meta-analysis of multiple different studies in non-ischemic idiopathic cardiomyopathy, again showing consistency across numerous studies that the presence of fibrosis is associated with worse all-cause mortality, with worse heart failure hospitalizations, as well as with a composite endpoint of arrhythmic endpoints, so sudden cardiac death, aborted sudden cardiac death, or need for appropriate ICD therapy. And then I'm over time here, but let me just finish with this one last one, which is hemochromatosis. And so CMR, I think, now has a very useful methodology by which we can actually identify the extent of iron content within the myocardium. And it's a technique called myocardial T2 star. And it's actually a fairly simple protocol to do. Literally, it's one breath hold. So, now we have all of these liver transplant evaluation patients that they're concerned about cardiac involvement. Literally, the patient can go in and out of the scanner within a minute or two. And what this does is it actually allows you, and I don't want to bore you with the physics of how this works, but it basically allows you to identify what we call the T2 star decay within the myocardium. And that correlates very closely with iron content. And this has been shown now in numerous pathologic correlation studies. And most importantly, I think, is in fact that with the advent of this study in the late 1990s, or this technique, in England, where they tracked this very closely, they found a significant reduction in the incidence of cardiac death due to iron overload in their thalassemia patient population, because now all these patients get their transfusions kind of titrated or adjusted based on assessment of the cardiac iron overload or cardiac iron load. So to wrap up here, this is kind of a nice cartoon which identifies, again, the differing patterns of hyperenhancement that you'll see with differing etiologies. So in ischemic heart disease, you tend to see subendocardial or transmural pattern of hyperenhancement, whereas in non-ischemic heart disease, you may see a mid-wall, an epicardial, an RV insertion site dot. Here's other examples of epicardial. But again, although these patterns don't necessarily give you one exact diagnosis, they can help you cone down the particular diagnosis. And you put this in the context of other findings, I think it can help us make a more accurate diagnosis than just simply non-ischemic cardiomyopathy. So I think to wrap up, the role for CMR, I think, obviously is in identifying LV function and determining if it's HFpEF versus HFrEF, in identifying the presence or absence of coronary disease, and then lastly, the presence of LGE in patients with myocardial dysfunction with cardiomyopathies can aid both in prognosis as well as in diagnosis. So thank you for your attention. And then maybe just if there's a pressing question or two.
Well, a comment and a question. The case you showed of sarcoid, the echo didn't move, but even standstill, it looked like the asymmetric septal hypertrophy was there too.
Yes.
It's a beautiful example because if you had stayed in the world of echo, you may have gone into, this patient may have an initial presentation of HCM and goes to the HCM mode of therapy. So it was a very nice case because actually presented with a picture by echo that could lead somebody towards HCM rather than towards sarcoid.
Right.
The question is in acute myocarditis, okay, is the hyperenhancement infiltration, inflammation, edema, or scarring. Do we
Yeah.
know a little bit more about it?
Yeah.
Are there any serial studies
Yeah,
showing
yeah.
that it
So,
goes away or it stays?
Yeah, so and I had a slide that I took out because of time. But yeah, so the reason you get hyperenhancement is basically there's an expansion of the extracellular space, right? And that space is expanded because of myocyte necrosis as well as kind of an inflammatory process that occurs. Now, what happens in follow-up? So there's been studies that have looked at follow-up, and the hyperenhancement pattern, or the myocyte injury obviously has occurred, will lead to persisting hyperenhancement. But the thing is, as a lot of the edema and everything resolve and it transforms to a scar, the size shrinks down. So now what can happen though is if you have a very small area to begin with, as the size shrinks down, it may now be below the resolution of your technique. So it may appear as if it's going away, but in fact it's not really going away, it's just gotten much smaller.
And that hopefully is a better prognosis too. Hopefully.
Yeah, if there's
He had gotten smaller.
because what it tells you there was a small burden to begin with, right? Yep. Okay. Any other?
How about stress cardiomyopathy? Is there something that can differentiate it? I mean, is there any edema without necrosis that imaging can tell us one way or another?
Yeah. So, yeah, and I took that slide out there. In that particular study, they did look at water imaging as well, and they found that there was some increase in water content in these individuals without the presence of any late gadolinium enhancement. The challenge with that is that the edema imaging techniques, in the classic cases that I showed you, it's fairly straightforward and simple. When you have a significant wall motion abnormality, you get slow flow. And that slow flow leads to high signal as well. So it can be kind of a mimicker. So there's newer techniques that are being developed that are kind of flow independent. But that particular study that I showed was about 6 years old. So as of now, I would say, we're somewhat skeptical on being able to look at edema imaging in the setting of significant wall motion abnormality because of the mimicking slow flow effects. But I think in that case, the wall motion abnormality, but the absence of any hyperenhancement is kind of your clue. Yep. Okay. Yeah. Another question, John. Pardon me? No, slow flow in the cavity that's sitting right next to the myocardium. So you see this area of increased signal, but it's hard to then differentiate, is this within the myocardium or is this within the cavity that's kind of mimicking that. Okay? All right, thank you.
Thank you.
Yeah, I know. I tell you, no, this is good. This is very good, yeah.